Stacie Geller is professor in the Department of Obstetrics and Gynecology and director of the Center on Research for Women and Gender. She has published over 75 peer-reviewed manuscripts. Dr. Geller is the PI of the NIH Birch Program, a K-12 institutional career development grant for women's health researchers, and has mentored faculty members and fellows in research and career development. Since joining the faculty in 1995, Dr. Geller has played an integral role in women's health domestically and internationally. Her global maternal health work has had some of the greatest impact around the world.
In 1973, I had a baby boy. I was young, naive, and had a very negative experience around the delivery. I felt as if I had no understanding of what was happening, despite the fact that I had read many books and felt a definite lack of control. I decided I needed to do something, that other women shouldn't have the same experience, that things should and could be different. I began working at Chicago Women's Health Center, a feminist women's health center focused on providing services to women by engaging them in their own health care. I began as a health worker and ultimately became the director of the center. During my tenure there, I began our maternity services program to provide prenatal and delivery care. I had no previous clinical training and received training as both a doula and a lay midwife. I was able to provide the kind of experience I never had while pregnant or delivering, and it was one of the most worthwhile experiences of my life. Although caring for pregnant women and delivering babies was very gratifying, I began thinking about other life opportunities. I returned to school and received a master's in public health and policy, and then very much surprised myself by deciding to go on for a PhD, then a postdoc, and ultimately a faculty position at UIC in College of Medicine and director of the Center for Research on Women and Gender. As an academic and scientist, I retained my passion for women's health and became a women's health researcher with a primary focus on maternal health. My research began, actually, in Illinois with funding from the Centers for Disease Control and Prevention to study maternal mortality and morbidity. We developed a model to identify women with severe and near-miss morbidity that has been validated since by the CDC and other researchers as the gold standard for identifying women with severe morbidity and has been advocated for use in Illinois and across the US. We realized we also needed to understand why these women move along the continuum of morbidity, and we developed a model to assess whether these deaths and morbidities were potentially preventable. Which factors, be they patient, provider, or system, contributed to the preventability of her illness or death. Our work on prevention has been translated from the science here to policy and practice. Our model is used to review every maternal death that occurs in Illinois up to 1 year post-delivery and soon to assess severe morbidity. Our preventability work has also been used in New Zealand, where I am working with Maori health providers and communities to improve maternal health. Our work was so successful that the Ministry of Health in New Zealand has mandated that every severe morbidity in the country be reviewed for preventability. The focus is on their indigenous population, whose health outcomes are far worse for their women and children. The government understands there that what is good for the Maori is in fact good for everyone in the country, and I'm very honored that our work has been adapted for an entire country. Although I've been working with disadvantaged populations in the US and New Zealand, these countries have many resources and advantages. I took my first trip to India in 1998 and realized how privileged we were in this country. My eyes were open to the conditions that the majority of the women in the world face when delivering babies, and there was no turning back for me. And I've since worked in Southeast Asia, the Middle East, and Africa. I focused on their most basic problem, that of reducing postpartum hemorrhage after delivery. Many women are still delivering at home or rudimentary health facilities without any provider or any medication. Our basic mission is simple. We work with local rural communities to educate villagers, health providers, traditional birth attendants, and pregnant women about safe motherhood. We want to ensure that every woman has a safe delivery. We encourage women to go to local health centers and work with midwives by engaging them in the process. As part of this effort, we introduced 2 very simple tools to reduce PPH and ensure safe motherhood. One is a blood collection drape for early identification of excessive blood loss. It is simple to use by any health provider or family member and allows for early diagnosis of PPH. It also provides a clean, contained area for delivery. The second is a drug called misoprostol that can reduce bleeding after delivery. This drug can be given to health providers, family members, or the pregnant woman herself. I've conducted numerous studies across the world using this drug, and our findings show we can reduce PPH by 50%, as well as the associated mortality and morbidity. This work has also been translated into policy and practice across the world, where governments have provided training to healthcare workers and distributed both the drape and drug. Each scale-up is a variation on a theme, but what is so important is that it is translatable in multiple scenarios. One of my latest initiatives will take place in Tanzania, where for the first time we will take the model of rural misoprostol delivery to a large urban area of Dar es Salaam. And I'm working there with an anthropologist, which is interesting in itself, to redefine community distribution. Our work with the drape has also transformed into an innovative idea, which you heard about previously. Although misoprostol works well, some women will continue bleeding with limited ability to be transported to a hospital in a timely manner for blood transfusion or even able to get a clean blood supply. Our hope is to be able to collect the blood from the drape that the woman loses post-delivery, filter it and transfuse it back into the woman before she goes into shock and dies. A woman can bleed out in 2 hours, and this potentially buys her time to get to a hospital and find a clean blood supply. And this is supported by UIC. I feel privileged to do the work I do and reach the women I care for. The ultimate goal is a healthy woman and baby. On a personal note, I'm about to become a grandmother for the first time. So in a sense, the cycle is complete. My son is having a son. The personal became professional for me many years ago and is now personal again. Thank you.